Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is HIV and co-infections covering hepatitis and leishmaniasis. And the speaker is Dr. Madhuchhanda Mandal Kayal. Dr. Madhuchhanda Mandal Kayal ma'am is working as the Assistant Professor of Tropical Medicine with the School of Tropical Medicine, Kolkata. She also works as the Nodal Officer Treatment at the Treatment Center National Viral Hepatitis Control Program, STM. Her areas of interest include infectious diseases, diabetology, and other endocrine disorders. We welcome you, ma'am, for today's session and request you to start the session. Ma'am, you'll have to unmute.
Hello.
Yes, ma'am, you're audible.
Should I start right now?
Yes, ma'am.
Okay. Good afternoon, everybody. Today we'll be discussing on the co-infections between HIV and hepatitis B and hepatitis C. So first we'll deal with HIV and hepatitis B co-infection, followed by HIV and hepatitis C co-infection. So all these three viruses, that is hepatitis B, HIV, and hepatitis C, they share similar routes of transmission. And the prevalence and burden of hepatitis C virus co-infection among people living with HIV are 6.2%. And the prevalence of HBV co-infection are 7.6%. So as we have already said that HIV and HCV have common routes of transmission, and people living with HIV, especially those who inject intravenous drugs and MSM people, that is men who have sex with men, they have always the increased risk of HCV infection. And viral hepatitis is also an increasing cause for both mortality and morbidity among people living with HIV, including those on ART also. And the concurrent or sequential infection with these viruses result in more severe and progressive liver disease and higher incidence of cirrhosis and hepatocellular carcinoma and related morbidity as well as mortality. So the estimated national prevalence for hepatitis B, it varies from 0.89 to 1.01, and risk of developing chronic infection of hepatitis B is different in different age groups and by their routes of transmission. The following perinatal infection, when the infection has been transmitted from mother to child, the chances of chronicity is more than 90%. And it is 20 to 60% when the infection has been transmitted or the infection has been received between the ages of 6 months and 5 years. And the rate of infection and the progression towards chronicity decreases to 5% when the infection has been occurred during adulthood. So the earlier the infection has been transmitted or has been received, the chances of chronicity is more. This is the dictum. And what we say about acute hepatitis B virus infection, this is the new onset of hepatitis B infection that may be symptomatic or asymptomatic, that may be either icteric or anicteric also. So when we are going to discuss the natural history among the HIV hepatitis B co-infected subjects, the impact of this co-infection on progression of HIV, there will be faster CD4 decline when both the infections are found in the same person. There will be slower CD4 recovery following ART. There will be increased chances of immune reconstitution syndrome in forms of hepatitis following the introduction of ART, and chances of antiretroviral drug-related toxicities will be higher, and chances of incidence of AIDS will be much more, and thus the mortality also. Now, what will the effect of co-infection on progression of HBV? There will be faster progression, the rapid progression to cirrhosis. There will be rapid progression to hepatocellular carcinoma, and the chances of treatment response that may also be affected. That is, decreased treatment response will be there, and higher liver-related morbidity will also be found in HIV, HBV co-infected subjects. Now we are coming to the evaluation. How to evaluate the co-infected subjects of HIV and HBV. Now, the persons who have newly been diagnosed with HIV, they should be screened for hepatitis B surface antigen at the very outset. And among these persons, newly detected HIV persons who are found positive for hepatitis B surface antigen should be evaluated further according to the technical guidelines for management of hepatitis B, which is under the National Viral Hepatitis Control Program by Ministry of Health and Family Welfare Department of India. So initial evaluation, of course, it will look for the history. A proper history has to be taken, and the following routine clinical evaluation for signs and symptoms of cirrhosis and hepatic decompensation in the form of either jaundice, conjunctival hemorrhages, presence of anemia, spider angioma, palmar erythema, petechial spots, presence of clubbing, gynecomastia, testicular atrophy, parotid enlargement, whether there will be decompensated liver disease, and presence of encephalopathy. There should be liver flaps or flapping tremors, ascites, edema, and different other findings, and splenomegaly. One should be very vigilant about this presence of these clinical findings, because this will help us to diagnose presence of chronic liver disease and its complications. So following the clinical evaluation, we'll go for the laboratory investigations. The laboratory investigations will be the first routine hemogram and blood biochemistry in the form of liver function test, prothrombin time, and to screen for presence of HCC, hepatocellular carcinoma, we have to do the investigations for serum alpha fetoprotein, ultrasound of abdomen, and if possible, the upper GI endoscopy where this is indicated. So the upper GI endoscopy is indicated where we are suspecting there is decompensated liver disease, presence of cirrhosis is there. So portal hypertension in form of splenomegaly may be there. There is history of variceal bleed in form of melena or hematemesis. We can do upper GI endoscopy in those cases to find the presence of gastroesophageal varices. So these investigations have to be done. And obviously, the presence of hepatitis B surface antigen has to be strengthened by the presence of the virological examination, that is hepatitis B virus, sorry, DNA quantitative assay by PCR. Now, staging of cirrhosis. Earlier, different invasive procedures like liver biopsy were used. Still, till this date, liver biopsy is the gold standard for staging of liver cirrhosis. But nowadays, various non-invasive tests are available, which are easily available. And of course, non-invasiveness is there, the first thing to be considered. The newer techniques like liver elastography, that is fibroscan, measures liver stiffness and determine the stage of liver cirrhosis. And National Viral Hepatitis Control Program also recommends the investigations like non-invasive techniques like APRI, that is aspartate to platelet ratio index, and fibrosis 4, shortly called FI4. We'll come to this in details later, and childpox coding for staging of cirrhosis. So with this knowledge, we'll consider the treatment of how to initiate the treatment of HIV and hepatitis B co-infected subjects. What to be considered at the very beginning, and what are the special things to be kept in mind for treating this special group of co-infected subjects. Firstly, all hepatitis B and HIV co-infected patients should be started on dual anti-HIV and anti-hepatitis B viral therapy, irrespective of the CD4 count, hepatitis B virus load, and or the status of the liver disease. They should be treated. And this treatment should cover both the HIV, human immunodeficiency virus, as well as the hepatitis B virus. This is the first thing to be considered. The patient should be linked to the designated treatment center or model treatment center under NVHCP, so that they can do their investigations done, or they get their required medicines from those centers and from the treatment centers. And if they get worsened, their conditions worsens, then they may be referred to the model treatment centers. Now, to ensure the provision of drugs for hepatitis, under NVHCP, only tenofovir and entecavir are available. And to access the investigations necessary for monitoring the response to treatment and monitoring for complications that I have already mentioned, the main complications are cirrhosis of liver and HCC. So they should be linked to the treatment center or model treatment centers. And for HIV, on HIV side, the recommended NRTA drugs for ART, the preferred regimen are tenofovir with 3-TC, that is lamivudine, or emtricitabine, sorry. This should be the backbone. Now, all people co-infected with HIV and HBV should therefore receive a tenofovir-based ART regimen in combination with either 3-TC or FTC, that is lamivudine or emtricitabine, as the NRTI backbone of an ART regimen, regardless of the stage or disease or HBV DNA level. Because these co-infected subjects for HIV, we used to consider them as stage 4 disease. And if antiretroviral drugs need to be changed, either to the alternative regimen or to the second line due to an HIV drug resistance or toxicity, then tenofovir with 3TC or FTC that should be continued together with a new ARV drug. This tenofovir and 3TC backbone should be continued because these two drugs are the backbones for both HIV as well as HBV therapy. Now, for abrupt treatment discontinuation of tenofovir or 3TC, this may be associated with reactivation of the drug, disease, hepatic flares, and in rare cases, up to hepatic decompensation may also occur. So, this should be avoided. Now, if stopping of tenofovir based ART should be, I have already mentioned that stopping the tenofovir based ART should be avoided in HIV and HBV co-infected subjects for concern of severe hepatitis flare and decompensation. Now, the ART guidelines for this co-infected subjects are that all people diagnosed with HIV infection should be initiated on ART regardless of CD4 count or WHO clinical staging or age group or population subgroups. And the choice of regimen should be that the drugs which have the dual activity against both the viruses, that is tenofovir and lamivudine, should be included in the first line of ART regimen in HIV patients who are hepatitis B surface antigen positive. So, to align with the preferred regimen for any other treatment naive people living with HIV is tenofovir, lamivudine, and Dalton, which is the current first line drug for initiating the antiretroviral therapy. Tenofovir 3TC and dolutegravir, these are the preferred regimen, but when there is some issues about the nephrotoxicity or bone toxicity for tenofovir, which has to be replaced by abacavir in tenofovir toxicity or in other contraindications. However, in such cases, second drug which is active against hepatitis B should be added. That is, when abacavir, 3TC, and dolutegravir is being used in a co-infected subject, tenofovir, there is only effective drug against hepatitis B is 3TC. So the second drug that is effective against hepatitis B should be entecavir. That has to be added in this regimen. Now, in case of renal toxicity, there should be replacement of tenofovir by abacavir, and the dosage of 3TC, that is lamivudine, that has to be adjusted. And in these cases, management of hepatitis B must be ensured using other drug that I have already mentioned, that is entecavir, which is available under NDHCP treatment centers, has to be used. For second line regimen, it has to be kept in mind that if 3TC is continued as part of second line ART following initial ART failure, even if it is used in the first line regimen, it has to be continued. And tenofovir should also be continued if not contraindicated for second line regimen to manage hepatitis B and to prevent any flares or decompensation due to discontinuation. There is another important issue, that is hepatitis B virus resistance. Ideally, the 3TC should be used either with tenofovir or not at all, because hepatitis B virus resistance to 3TC develops quickly. 3TC should never be used as monotherapy. And it has been found that HBV resistance to 3TC develops very quickly, and it develops in almost 50% cases of co-infected subjects after 2 years, and in 90% after 4 years of treatment. So there should be at least 2 drugs which are effective against both HIV as well as hepatitis B. So this point I am giving so much stress because this should be kept in mind to avoid HPV resistance. Now, what are the problems that we face when we are treating hepatitis B patient and his or her ART has been started? HBV flares, which are very common, they start soon after the initiation of ART, and it is a manifestation of immune reconstitution syndrome, and discontinuation of 3TC and tenofovir that also may result in hepatic flares. So these cases has to be addressed. And among tenofovir and among lamivudine and emtricitabine, the rate of suppression of HBV and the safety profile and resistance pattern with emtricitabine are just like those of lamivudine. But emtricitabine is not being a part of national ART program. We only consider 3TC while treating the hepatitis B and HIV co-infected subjects. So whenever TDF is substituted with zidovudine, it is seen that lamivudine remains the only active anti-HBV drug in the ART regimen, and another agent active against hepatitis needs to be considered according to the guidance provided by the National Viral Hepatitis Control Program. So a proper referral has to be made to the model treatment centers at early stage of diagnosis, so that the appropriate management should be given to the subject. Now, while we are discussing about the treatment management of hepatitis B and in HIV patients, we should also consider the prevention of hepatitis B infection, as prevention is the mother of cure. HBV immunization required in those persons in newly diagnosed with HIV but who are negative for hepatitis B surface antigen. Then we can consider of hepatitis B immunization, and also in infants who are born to hepatitis B positive mothers. And hepatitis B immunization will not be required in subjects who are already hepatitis B surface antigen positive. That is, either he or she has been already infected with hepatitis B. And past hepatitis B infection, which has been functionally cured with protective titer of anti-HBs antibody more than 10 milli-IU per ml. That is, the protective antibody against hepatitis B is already present. So their hepatitis B immunization is not required. Now, response to hepatitis B vaccine in the general population, and in HIV populations are a bit different. In persons with HIV, or especially with the low CD4 count, the response to HBV vaccine is a bit lower. So this, the all infants born to hepatitis B positive women, they need to be immunized within the very early. They have to be immunized with 0 dose, and total 3 or 4 doses has to be given, and the dose is 10 microgram intramuscular in the anterior thigh, and hepatitis B immunoglobulin that has to be given as part of active and passive immunization within first 12 hours of birth. So following this, we are coming to the co-infection between HIV and hepatitis C. Hepatitis C virus accounts for nearly 12 to 32% of all cases of liver cancer and 10 to 20% cases of cirrhosis of liver, both of which have high treatment costs and poor outcomes. National seroprevalence for hepatitis C has been found 0.32%, which varies from 0.28 to 0.36%. And in India, the estimated figure of 52 to 130 lakhs has been found who are infected with hepatitis C. So while we consider the natural history of hepatitis C, following acute hepatitis C virus infection, almost 15 to 45% get resolved. And out of the remaining 55 to 85% of subjects, they become chronic hepatitis C. And the major amount of 85 to 90% of those chronic patients are stable hepatitis C, and only 10 to 15% of chronic hepatitis C goes toward cirrhosis. And those cirrhotic hepatitis, chronic hepatitis C subjects, almost 75% are slowly progressive disease, and 25% of those cirrhotic patients of chronic hepatitis C, they either give rise to hepatocellular cancer, carcinoma, or liver failure. So large majority is a resolved patients. A large majority of the cirrhotic patients, they are slowly progressive disease, and chances of HCC are lower. While we discuss the natural history of HIV and hepatitis co-infection, just like hepatitis B and HIV, these presence of the two viruses, they affect each other's disease. There will be obviously when the co-infected subjects with HIV, there will be rapid HIV progression. And just like hepatitis B, the CD4 recovery following starting of antiretroviral therapy will also be decreased and impaired. And in presence of HIV, the HCV disease, the natural history, there will be acceleration of progression to cirrhosis. There will be accelerated progression to decompensated liver disease, and also to hepatocellular carcinoma. So the presence of co-infection in a subject of hepatitis C and HIV is obviously more progressive and accelerated than the hepatitis C mono-infected patients. Now, it is recommended that all injection drug users have to be screened, and those with multiple blood or blood product transfusions, or those persons who have their liver enzymes, mainly ALT, raised more than 2 times the upper limit of normal where the cause is not known. And obviously, based on the strong clinical suspicion, one has to be screened for hepatitis C. And the test that is used to detect the anti-HCV antibodies, they have to be done. Anti-HCV antibodies develop as a part of acute infection. Once they develop in a body, they normally persist throughout life. So the mere presence of anti-HCV antibodies never confirms the presence of active disease, because among those infected, 40% may clear the virus, but still they may have the persisting antibodies. So in persons who have this anti-HCV antibodies, in them a nucleic acid test, that is NAT for HCV RNA or HCV RNA PCR, which detects the presence of the virus, is needed for the confirmation of the diagnosis of chronic HCV infection. So it has to be kept in mind while treating a patient of HIV and HCV co-infected subject that this mere presence of anti-HCV antibody is not sufficient to initiate treatment for hepatitis C. There should be active presence of the RNA. That is, the virus should be present. There should be detectable viremia in that co-infected subject. So, just like hepatitis B, here also a detailed history about the patient, whether he or she is having repeated blood transfusions for any medical conditions, or having hemodialysis, repeated hemodialysis, or subjects who are incarcerated, or who have multiple sexual partners, or persons who are having sex with men, the men having sex with men, or female sex workers. They are the more vulnerable people who get these two infections together. And among those subjects who are having tattoos, different traditional whatever I say, rituals like piercing, etc., body piercing from unsafe sites, they may have this chances of both co-infections with HIV and HCV. So this history is very important. And for physical examination, obviously, it's the hepatitis C also affects the liver. So there may be presence of jaundice, organomegaly in the form of hepatosplenomegaly. In decompensated disease, there should be ascites, there can be ascites, or cirrhosis, or other features of decompensation, like variceal bleedings and other features like that I have already mentioned in case of hepatitis B disease. This can also be present in hepatitis C also. So following clinical evaluation, the laboratory tests should include complete hemogram, liver function test, prothrombin time, alpha fetoprotein, etc. Why we do the complete hemogram? We'll see that the platelet count will be required to calculate the non-invasive test like APRI or FeV4, because from complete hemogram, the platelet count is very much required. And among the different liver enzymes, both the AST and ALT, their levels will be required for calculating the FeV4 or to see whether the transaminitis is already present for last 6 months or it is more than the normal levels or 2 times more than the upper limit of normals. That we have to find from this LFT. And deranged prothrombin time also gives a hint about the presence of chronic liver disease. And alpha fetoprotein is to screen for the presence of HCC, etc. And among other tests, the abdominal ultrasound. Abdominal ultrasound will help us to find the size of the liver, the ecotexture of the liver, whether it is normal sized, there is hepatomegaly, or this is shrunken liver, that is coarse ecotexture, altered heterogeneous ecotexture is there, with presence of nodules, that is presence of cirrhosis is there. And abdominal ultrasound also may help to see the portal venous size, that is portal venous, there is portal hypertension is present or not, or presence of ascites, etc. may be seen. And endoscopy, upper GI endoscopy will help us to find the presence of varices, the esophageal or gastroesophageal varices are present or not. And for the assessment of liver fibrosis, we are nowadays using the non-invasive tests like elastography, that is FibroScan, or we are calculating the APRI and FeV4. So APRI is basically the aspartate to platelet ratio index, where the aspartate level is divided, the AST level is divided by the upper limit of normal, whole has to be divided by the platelet count, which is found, the platelet count per into 10 to the power per liter, the platelet count per liter. Platelet ratio has to be determined. If there is presence of 1.5, that will show that there is presence of fibrosis, and APRI, if it is more than 2, then it shows that there may be presence of cirrhosis. And for FeV4, the AST level, ALT level, these are required, and age of the patient, these are the few things required to calculate FeV4, and these are very easily available from the internet. So you can calculate the APRI and FeV4 at your clinic. If the complete hemogram level, complete hemogram report is available and the LFT report is available to you, you can calculate within seconds. And the presence of fibrosis or presence of cirrhosis can also be calculated within few seconds at your clinic. Now, after evaluating the patient, we'll obviously go for the treatment. And for the treatment of HIV and hepatitis C co-infection, previously interferon and ribavirin combination were being used, but nowadays the newer treatment, that is with directly acting antivirals, these are available, easily available, These are all oral drugs, so no injections have to be taken, and no hospital stay is required, because these are provided as OPD treatment. The oral medicines with very few side effects. The whole treatment for hepatitis C has been revolutionized, and the SVR rates, that is sustained virological recovery rates, are with DAA-based therapy among people with HIV co-infection are just comparable to those persons with hepatitis C monoinfections. The sustained virological response 12, SVR 12 is the response rate that is seen following 12 weeks after the completion of DAA treatment. That is said to be SVR 12. So SVR 12 rates are almost same, almost more than 95% among both HIV co-infected subject or those persons without HIV having only hepatitis C monoinfections. All people living with HIV who are having this hepatitis C co-infection, they are to be linked to the treatment center or model treatment centers under NVHCP as the free evaluation and treatment for all those infected subjects are provided by this treatment centers. And the decision whether the ART, we have to start the ART among people co-infected with HCV should follow the same principles as for HIV monoinfection. This has to be kept in mind. So this is the testing algorithm for viral hepatitis in patients of jaundice. This algorithm is provided by National Viral Hepatitis Control Program. So we'll consider this testing algorithm. The specimen should be the serum or plasma. So for under NVHCP, all these 4 hepatitis viruses are being tested for acute hepatitis, for hepatitis A. For hepatitis A, we usually do the IgM anti-HBV. If it is reactive, then the report is HIV positive. And if IgM anti-hepatitis A virus is non-reactive, then the subject is found to be HIV negative. And for hepatitis E virus, it is also the anti-HEV antibody being done. If found reactive, then reported as HEV positive. And if non-reactive, obviously HEV negative. And for hepatitis B, we usually do the hepatitis B surface antigen. This is the basic screening test. If found reactive, then the subject is thought to be hepatitis B infected. Along with hepatitis B surface antigen, we also do the IgM anti-HBC. IgM anti-HBC is anti-HB hepatitis B core antigen. It is present following acute infections. So acute infection with hepatitis B. So if IgM anti-HBC is reactive along with hepatitis B surface antigen, it is said the subject is hepatitis B positive and probably having the acute infection. And if the hepatitis B surface antigen is reactive, but IgM anti-HBC is non-reactive, then also the subject is said to be hepatitis B virus positive, because it can be a chronic infection also. And if both are reactive, this is also hepatitis B positive. If both are non-reactive, then it is hepatitis B non-reactive. negative. And for hepatitis C, in a patient with jaundice, if it is anti-HCV antibody is reactive, the report is hepatitis C virus antibody positive. So I have already mentioned that mere presence of anti-HCV antibody does not tell us about the viremia or the presence of virus of hepatitis C in the body. So it is reported as hepatitis C virus antibody positive. Now, in a patient of viral hepatitis without jaundice, the testing algorithm is for hepatitis B and hepatitis C. The screening test is with surface antigen for hepatitis B and anti-HCV for hepatitis C. And it is same if the hepatitis B surface antigen is reactive, the subject is reported as hepatitis B virus positive. And if found non-reactive, the report is hepatitis B virus negative. And for anti-HCV antibody reactive subjects, it is reported as HCV antibody positive subject. So we're coming to the management approach in hepatitis C and HIV co-infected subjects. Under the National Viral Hepatitis Control Program, for management of hepatitis C, 4 drugs are available. That is sofosbuvir, daclofenacin, velpatasvir, and ribavirin. The sofosbuvir, either as sofosbuvir 400 milligram tablets or with fixed dose combinations between sofosbuvir and velpatasvir, and daclofenacin is as 60 milligram or 30 milligram of daclofenacin. Treatment is currently recommended for subjects who are older than 18 years of age. We are not treating the pediatric populations nowadays through our National Viral Hepatitis Control Program. And the place and the choice of regimen is influenced by the stage of the disease. Either there is cirrhosis or no cirrhosis, and other comorbidities or complications present in the subject. Now, all treatment naive patients for hepatitis C who are not having cirrhosis or any other complications, which are almost accounting for more than 80% cases, are managed at designated treatment centers under National Viral Hepatitis Control Program, and the complicated cases and retreatment cases are being referred to the model treatment centers. So the management approach in HIV/HCV co-infected subject like this: the people living with HIV who are confirmed with chronic HIV infection and they are also being detected with hepatitis C virus antibodies and HCV RNA, obviously. Then the baseline investigations are being done along with APRI, FIB4, and transient elastography if available. Now, there should be 2 groups of patients: the patients who have the cirrhosis and who doesn't have the cirrhosis. Now, in the uncomplicated non-cirrhotic subjects, the treatment should be started with sofosbuvir and daclofenacin for 12 weeks. And for subjects who are having cirrhosis, that is compensated cirrhosis childbirth A, the treatment is with sofosbuvir and velpatasvir fixed dose combinations for 12 weeks. And following the completion of the 12 weeks treatment, we have to perform the HCV RNA 12 weeks after completion of treatment. That is 12 weeks of treatment with this antiviral drugs have to be given. We have to wait for another 12 weeks. Following that, we can perform this HCV RNA retest. This is, at this point, we say this is SVR12 test. If HCV RNA is not detected, then the treatment is completed and we say the sustained virologic response 12 has been achieved. SVR 12 has been achieved. And if HCV RNA is detected, then SVR 12 has not been achieved, and this kind of subject has to be sent to the higher centers for further management. Now, in general, the clinical stabilization of HIV disease with ART is advised before starting treatment of HCV. And while the directly acting antivirals for treating hepatitis C infection have been revolutionized the treatment outcomes, it is also important that various drug interactions between the antiretroviral drugs and directly acting antiviral drugs are there. And this should be kept in mind always while treating these co-infected subjects. Now, the decision to start ART among the co-infected HCV subject, they should also follow the same principles as we start the treatment in case of HIV mono-infected subjects. The ARV regimen for new initiation remains the same, that is tenofovir, lamivudine, as well as the dolutegravir in single pill FDC for adults and adolescents. So various potential harmful effects of antiretroviral drugs, including their hepatotoxic effects, though these are very less new with the newer classes or newer generations of drugs nowadays, they have to be always be kept in mind. These drug-drug interactions may occur. Now, for most HIV and HCV co-infected people who are having cirrhosis, the benefits of ART always outweigh the concerns regarding drug-induced liver toxicity. So they should get the benefit of ART treatment, ART therapy, antiretroviral therapy. So these are the recommended regimens under NVHCP. The first is, I have already mentioned these groups, but this is systematically been shown here. The patients without cirrhosis in uncomplicated cases, sofosbuvir 400 milligram along with daclatasvir 60 milligram, each tablet has to be given for 12 weeks. And for childpack A, compensated cirrhosis with hepatitis C, they have to be given the fixed dose combinations of 400 milligrams sofosbuvir and velpatasvir once daily have to be given for 12 weeks. And those patients who are having decompensated cirrhosis, that is childpack B or C, the sofosbuvir and velpatasvir fixed dose combinations have to be given along with ribavirin, weight-based ribavirin from 600 to 1200 milligram. This is also for 12 weeks. But in those ribavirin intolerant patients who are having anemia and some other contraindications, but we have to give, we have to treat those decompensated cirrhotic patients. We have to give sofosbuvir and velpatasvir same dose for longer period, that is for 24 weeks. So this is the recommended regimens under NVHCP. And here a few important drug interactions we should mention, as we are seeing that along with, while we are giving antiretroviral in form of atazanavir and ritonavir, and we are giving daclatasvir in a subject, then the daclatasvir dose has to be reduced to 30 milligram per day instead of 60 milligram usual dose. The daclatasvir has to be, the dose has to be reduced. But if we are giving the antiretroviral therapy where the efavirenz or nevirapine are the components, then the daclatasvir dose has to be increased from 60 milligram to 90 milligram per day. These are the very commonly faced drug-drug interactions. So that we normally use in our day-to-day practices. So very few drug-drug interactions we have to keep in mind, and if we can take help of the different online drug-drug interaction sites like Liverpool's site for seeing the drug-drug interactions. And for monitoring of these co-infected subjects, we have to see the regular monitoring of liver and renal functions have to be done when using the directly acting drugs and antiretrovirals together, especially sofosbuvir is a nephrotoxic drug. And the regular monitoring has to be done. And additional monitoring of liver function has to be done in presence of cirrhosis. And patient who are having neutropenia, thrombocytopenia, or anemia, or they may also require monitoring very frequently. Every 1 to 2 weeks, they have to be monitored. And for prevention of hepatitis C in PL-HIV, there is no vaccination. There is no immunization against hepatitis C virus. So for no effective vaccine and for prevention of mother to child transmission, their protocol for prevention of hepatitis C, these are not available. And in injection drug users, the strict maintenance of disposal of needle, syringe, shelves, etc. at healthcare facilities should be maintained. And obviously, the safe sexual behaviors have to be practiced for prevention of hepatitis C. So with this, I come to end of my slides. Thank you.
Ma'am, Leishmaniasis has been covered.
No. Now I'm just telling you about the infections of HIV and Hep B. Hep B and Hep C. Yeah.
Okay, ma'am.
Sorry.
We'll continue for Leishmaniasis today, ma'am.
No. I was just trying to open the chat, but
Okay.
it's not.
Okay, so we'll
My
continue
cursor
the
is not
session later.
Yes. Yes.
Okay, I'll get in touch with you, ma'am, then.
Thank you.
Right. Okay. Thank you so much, ma'am, for facilitating this session. There's one question in the chat box, ma'am. Is HCV genotype necessary?
No. Nowadays, for treatment, HCV genotype is not mandatory, as because these directly acting drugs are mostly pan-genotypic. So without doing the genotype, we can directly go for treatment.
Thank you, ma'am. Any more questions from the participants? Please feel free to unmute your mic. Ma'am, I don't think there are any questions. We'll continue the session later as per availability from ma'am.
Okay. Thank you.
Thank you, ma'am. I'll just quickly run the feedback form, ma'am. The feedback poll is has started or shared. Okay. The feedback poll is now visible on your screen. Please go through all the 4 questions and answer them.
Do I have to do this?
No, ma'am. No.
Oh, other people.
No.
Okay.
Requesting all the participants to please take the feedback poll. Praveen sir, is the e-poll being answered?
I think 15% of
Okay,
participants.
sorry, it's not visible to me. Requesting all the participants to please fill in the feedback poll. Once again, thank you so much, ma'am, for facilitating this session. Thank you to all the participants for patient listening. Praveen sir, we can end the feedback poll.
Thank you.
Thank you.
Thank you. We'll conclude the session now.